Sure. So treatment in the elderly population is, a large factor in all of myeloma therapy, as many of our patients are older. And being older is not just defined by age. In fact, it's really a combination of people's age, but also their comorbid conditions and other factors in their life. And as we look at therapies and think about particularly the older transplant ineligible population, we now have some good data from recent studies looking at different triplet therapies that may improve progression-free and overall survival for older patients. Our data, RVD Light, has been published looking at upfront dose modifications of lenalidomide and bortezomib, specifically upfront reductions in the lenalidomide dose and the frequency of bortezomib. We had very good outcomes with that, both in terms of tolerability and progression-free survival. More recently, published in the New England Journal of Medicine, was the MAIA study, adding daratumumab to lenalidomide and dexamethasone with outstanding results favoring a triplet combination versus the traditional doublet of lenalidomide and dexamethasone. I think both are fantastic options for our patients and really highlight just the improvement in myeloma therapies that we're able to offer. I think deciding which therapy to use can be a challenging question for providers now that we have so many good options, particularly improved in the upfront setting. A lot of it comes down to the actual patient. When looking at the older patient, it's beyond just age, it's also comorbid conditions, but also the logistics and qualities of their life that would make one regimen more favorable than another in terms of the administration. I think what we've seen through the MAIA data, and also though ours was not randomized, is improvements in quality of life. And specifically, there were improvements in quality of life in the MAIA data for those receiving the triplet versus the doublet. All patients improved on therapy, but the difference was more significant in those receiving the triplet. So even though we may ask more of our patients and having them come for whether it be once weekly bortezomib or a graduated schedule of daratumumab, it is feasible, and in fact patients do better and have improved quality of life in the data that we see. Again, it's not only about the drugs, but it's how we give them, making appropriate dose modifications when necessary to things like the dexamethasone if patients have side effects such as insomnia or mood alterations, which will ultimately enhance the tolerability of these regimens. Going forward, I think we want to build off these exciting data. Can we make it even better for older patients? Can we go to an all-oral regimen through the Alliance? We will be studying the combination of ixazomib, which is an oral proteasome inhibitor, with lenalidomide, dexamethasone, and daratumumab. We anticipate that will be opening shortly. So can we ultimately create a regimen that's primarily oral but add daratumumab to increase the efficacy? Will we look at other newer therapies in the relapse refractory setting of our CAR T cells and other exciting immunotherapies in the older population specifically? I think there are a lot of unanswered questions about how we can best help this population, but we've got a great start with recent data that's been presented. The upfront setting, so areas that need to be addressed continue to be where in the older population do we draw the line for autologous stem cell transplant when we're seeing such great results, particularly with the addition of monoclonal antibodies. Can we continue to increase the efficacy and tolerability? We also have to address maintenance. What is the correct maintenance strategy for an older patient? Is it necessarily to continue to do infusional therapy as part of maintenance? Is there a timeline for maintenance? We know from the first study that continuous maintenance improves progression-free survival, but at this point we don't have specific data in terms of long-term use of, for example, triplet maintenance therapy in the high-risk population. Would that be something better? So there are a lot of questions that we can continue to answer and think about in our clinical trial design. Can we use MRD negativity to help guide the maintenance therapy we choose for our patients if it means that there's a improvement in quality of life through decreased visit burden? Can we use other techniques such as MRD to help guide us in our management of our patients to make treatment more feasible? So I think we have there's still exciting stuff to be presented at this meeting. We're all excited to look at the Griffin data, which we should be hearing about on Sunday. At ASH, we continue to look forward to hearing about some of the newer therapies, specifically CAR T cells and the BiTEs and the drug antibody conjugates. All of these are exciting therapies, not so much for the newly diagnosed population, but we're looking for readouts of some of the other studies too, comparing triplet combinations in younger patients that hopefully we can think about and extrapolate some important pearls from our older patients as well.